So welcome everyone to the Ignite Digital Conference. My name is Dr. Adam Kassem, and I'm the president of the Ontario Medical Association, and I'll be helping to moderate today's very exciting discussion on the future of healthcare. Now, it comes as no surprise to anyone here that the past 20 months of fighting COVID has fundamentally changed the way in which we think about healthcare and its delivery. But we're also at a tipping point. And what does that mean for the future of healthcare and whether this moment will potentially serve as an opportunity to reshape our systems of care? Now, for context, the Canadian healthcare system has been under great strain as a result of the pandemic. In fact, this has been true even before COVID-19. And there have, of course, been concerns around capacity, around supply chain management, around health human resource shortages and planning, and ultimately the health disparities between communities. And we've also experienced a shift in the way in which the healthcare system has rapidly adopted new innovation and technology in order to meet the growing demands and needs of patients. So our esteemed panel includes two special individuals. The first is Dr. Zaina Kaya, who is the Vice President of Business Development and Strategy with Teladoc Health in Canada, advancing Teladoc's mission to provide a new kind of healthcare experience with greater convenience, outcomes, and value. From 2018 to 2021, Dr. Kaya was the future strategist with St. Elizabeth Healthcare, a national social enterprise providing home care health solutions and education to people where they are and where they need it. She also led the Health System Innovation Platform at Mars Discovery District, a major innovation hub in Toronto from 2014 to 2017. Dr. Catherine Smart is the president of the Canadian Medical Association and a past president of the Yukon Medical Association. She is a practicing pediatrician in Whitehorse, Yukon. Her work is centered on developing collaborative partnerships with community and government services to serve marginalized children using a model of social pediatrics. She works primarily with children who have experienced trauma and adverse childhood events, and she witnesses the broad and lasting impact these events have had on children and their development on a daily basis. She is passionate about improving services of marginalized children in an effort to change their life trajectory. And in addition to her community-based work, Dr. Smart enjoys acute care and provides on-call services to the hospital. Before moving to the Yukon, she was a pediatric emergency medicine physician at the Alberta Children's Hospital in Calgary. So thank you both for being here today and sharing a little bit of your time, your precious time that you have with you and your families. And so we really appreciate it. Let's start with maybe a broader question for both of you. And I think it has maybe some pertinence to our experiences over the past couple of years. So what has COVID-19 taught us about Canadian healthcare, and what is sort of the biggest lesson for us to learn about the future of healthcare in this country as a result of the pandemic? Maybe Catherine, maybe we'll start with you.
Thanks, Adam, and thanks for having me today. That's such an important question, and I think there could be a lot of answers. But what I've really been reflecting on since we've seen what's happened in the pandemic is our healthcare system as it stands really designed for the future, and is it really prepared and nimble enough to meet the needs of Canadians? And by Canadians, I mean not only patients, but also physicians and other healthcare professionals that work in the system. You know, in my view, I think a successful system has to work for people on both sides of it. It has to work for the people that deliver the care, and it has to work for people receiving the care. And I think what COVID has really made clear is right now our system isn't really doing very well for either of those groups. You know, a lot of the challenges we're seeing in the system, of course, have just been made worse by COVID. They're not new problems. They were there before. But of course, this has just brought everything, I think, to a new level because the system's under strain that we just haven't really seen. But I think the other difference is the awareness of that strain is much more front of mind now for Canadians from all walks of life. You know, before, I think as people in the system, we were quite aware of the strengths and limitations. And so were absolutely some Canadians. But now I think everyone in the country is thinking about our healthcare system. You know, it's top of mind. It was a top issue for Canadians going into the last federal election. And it's something I think that people are talking about every day. So I think now, you know, we really need to think as we emerge from this pandemic, where do we go from here? You know, are we talking about more of the same? Or is it time to actually really get down to the root causes of what is making our system not work, acknowledge that it's not meeting the needs of providers or patients, and really get serious about what those solutions could look like? So I think it's, you know, exciting to have people here that are really innovators and to learn from them about what they've done and how they're approaching some of these problems. Because I think sometimes our challenge in healthcare is because it's, you know, so valued by Canadians, which is great. But sometimes that, I think, can be a barrier to change because everyone's so worried about it not being, the system that they hope or want it to be, that they're afraid to actually make substantive change because of what that could mean. And I think we need to get over that. I think we need to address that elephant in the room. It's not really a universal health system. It's a universal illness system. Many things that people need are not part of the system. It's not working. Too many people don't have access to care. So let's get on with actually creating a system and accepting that innovation needs to be part of that to move forward so that the people in the system can be healthy and thriving and enjoy their work and do their best for patients, and patients can get the care that they need.
That's great, Dr. Smart. Thank you for that. And we'll maybe touch on a little bit of what you just described as far as how do we get to that point? What are the key recipes for success? What are some of those factors that we need to potentially come together on, whether it's provincially, federally, municipally, regionally, and how do we really move the ball down the field? Zaina, thoughts?
So I think Catherine covered a lot of ground of what's happened as we kind of got out of the last 18 months or 2 years. A couple things I'll just add. There were two other macro society things that are really agnostic to COVID that have also come together that really were not contemplated that much in our health system. One is, of course, the combination of Black Lives Matter, Me Too, and just this awareness of the inequities, like at a scale that, yes, COVID exposed massive inequities, but even more. And I think we can't go back. And so, going forward, everything in healthcare will be designed and delivered through a lens of equity. Well beyond what COVID did to that. And I think the other current, just reflecting on the COP climate conference in Europe, for the first time ever, and I've been in this sector a long time, the impact of healthcare on the environment, on climate, on carbon is now becoming a boardroom conversation. There was only a couple leading health orgs that thought about that. It's becoming top of mind. And both of those kind of social issues, the citizens who finance the health system and the people who work in the system, they want the best of their country on both of those fronts anyway. And of course, healthcare cannot be contributing to that. So I think those two things on top of everything we just heard, we had a radically unsustainable healthcare system before COVID. It is like really broke right now, like really, really broke. Every province, every federation, the federal government is under massive debt. There is no more money to finance healthcare. And yet we have a massive imbalance between supply and demand. I add on top of that, our health workforce, stressed, at the brink of breakdown everywhere, not just one population, not just one geography. Every type of health worker is leaving, is quitting. There's problems with suicide. We have a crisis of the workforce, and it's not just supply, like everybody loved to talk about before, like let's just go buy more workers. It's not that. So again, when you have this many crises, when the business model no longer works, when it doesn't work for people, we can't do what we've always done, I'd say for 45 years in Canada, which is commission another study and another report to summarize the same 10 things we've been saying for 50 years. Like we really, I feel, are at a precipice of rebasing, which is taking it apart and putting it back together. And that's kind of what the next era we're getting into.
That's really interesting, Zaina, because, what you just described here is government ain't going to be able to fund this in perpetuity. The demand on patients or for patients grows. We're an aging and a growing society. We have higher healthcare utilization, whether that's here in Ontario or in the Yukon or right across the country. And the supply of healthcare workers is precarious, whether it's burnout or an undersupply because of other regulatory issues or an aging workforce in many cases, at least in the physician community that we're seeing, at least here in Ontario. So what's the first thing? So if what's the first step? There are 10,000 problems. What is the first, right? What is the first step? And what is the first next priority that we need to really hone in on and identify as a need and ultimately act upon?
Look, there's a lot that's of possible things. I'll have to start with technology, and not because it's a fun, sexy thing to say. At the end of the day, okay, what does technology do, right? Technology replaces labor and capital. Capital is equipment and buildings and anything physical, right? It replaces or it makes that existing labor and capital more productive. That's what happened to agriculture with tractors and now with digital. So we are one of the laggards in the world in terms of a sector of just reaping the benefits of everyday modern technology, not even sexy, fancy technology, like just digital, right? We're about 25 years behind in Canada. So that alone will free up our scarce, precious humans who take up about 75% of all healthcare to use their time and their training and their expertise for things that really need their time and training and expertise, and let the machines take care of all the other noise. We obsess about beds and buildings and building more and more wings and more this. We don't need that anymore. There's no industry in the world that is growing capital in buildings. They're actually retracting, yet all we do is build more. So we can replace a lot of that capital with basically software, which is basically free. So that's the promise that allows the economics to finally be a little bit more sustainable. Secondly, it fundamentally changes the experience for both patients, as Catherine said, and staff. If they live a 21st century experience in every other thing in their life, and now they enter healthcare and they're back in the 19th century. So that's kind of, you're asking brains to go in two ways. So very different experiences are possible, which affects outcomes and cost and all those other things. I think the third big thing, if we modernize a bit more, is just we become an intelligence-based healthcare system, not an evidence-based healthcare system, right? When you run your services on intelligence, that means you're producing data in real time and acting, your cycles and your loops are in real time. Not what we do today is we wait for results that are about a year old, get an academic to interrogate them, get the results, and then 3 years later, we change policy. Like, no wonder we haven't modernized. And then the last thing, what technology will do, and I think Kashebji can tell us more later, is it allows us to now do things that were not even possible before. And that's exactly what we saw with the mRNA vaccine. Right? Look what we accomplished that we couldn't before, and that's a technology. So that's kind of what I see as those different layers of what technology brings, and we are just scratching the surface in Canada.
Yeah, thanks, Zaina. And there's no question that we need to be able to leverage technology in a different way, and perhaps a more meaningful way for patients, for providers, for the system, for cost effectiveness, all of these different layers that play into provision of healthcare. Catherine, we're talking about this issue of virtual care. Or at being able to scale it in a very efficient way. But there are certain challenges with virtual care as a provider, as a patient. We're seeing, for example, some of the delayed care or perhaps even inappropriate care as a result of virtual care or the advent of that. So how do you square that circle? How do you go from, we know that this is a very powerful tool that to be used and wielded in specific ways, but what are your thoughts on how do you balance those two competing interests?
Yeah, I think that's such an important question. It's interesting, right? I totally agree with the comments so far that, we are very slow to innovate and adapt in our industry. There's no question. We are living in the 1950s in so many ways. Yet because of COVID, we did really pivot to virtual care almost overnight across the healthcare sector, which is probably honestly the biggest, adaptation of an innovation or change we've seen in our lifetime in terms of just how dramatic that was and how many people just suddenly adapted it because they had to. But I agree with you. I think there's lots there that can be positive, but it did not come without some costs. And unfortunately now we're hearing about them, missed cancer diagnosis, delayed findings from not having had a physical exam, some patients not being able to have basic things done that needed to be done in person, and then that overloading our other systems. So how do we, what do we do about that? And I think the other challenge we have is, not everyone has access to the technology that you need to have virtual care. And that's certainly a challenge we have here in the North. The internet doesn't work very well. Even myself in Whitehorse, often the internet's not working, let alone in our communities. We have communities where less than 15% of people that live in that community actually have a smartphone or a computer or even access to, cellular data. So there are still lots of equity issues around accessing virtual care that I think need to be considered. And then I think the other piece, like you were saying, is, how do we balance what can be done in person and what needs to be done, what can be done virtually? And I think, this also links back to that issue of those longitudinal doctor-patient relationships that I think is another real challenge that's facing our system. And I think we're hearing more and more from people in primary care that, again, this 1950s model of how you provide primary care, it's not working for them. It's not working for patients. We have 5 million people without access to care. That's not going to be fixed just by getting more doctors. I totally agree. There is a supply issue for sure, but it's not the only piece of it, right? It has to be an environment where people want to work and they have to want to choose that type of work. And right now, that's not what we're hearing from that next generation of physicians. And I think that again links back to, how do we make virtual care work for us? Well, we need to be more innovative about how doctors are remunerated, where they work, how they work, and how virtual care can fit into that. Because if it's an either or, it's just not, I don't think, ever going to be effective. And we need better ways of understanding and being nimble about who needs to be seen in person. And I think that's a challenge we've had as well. We also, I think, need a lot more patient education about how to use virtual care in a good way. Like we're hearing from lots of providers, they have these appointments with their patient, they phone, they're in the lineup at the grocery store, they're driving on the road, these types of things. So how do we, set expectations on both sides around how we're going to use virtual care as a substitute or in addition to make it actually practical and workable. I think there is likely some room there for some of this, machine learning, artificial intelligence to help doctors better understand, what are these potentially high-risk situations? What are things we might be apt to miss over a virtual appointment, so that it's helping us know better, when do we really need to be sure someone's been brought into our office? I think the other piece is, most of what we're calling virtual care has actually been phone calls. And that's how a lot of patients have wanted to receive their care, is over the phone. And it's often been what's been most accessible to doctors and patients. And I've certainly found that here in my own practice. So a lot of people are nervous about coming online, or they don't have the internet, or they don't even have the technological ability to get themselves in the screen correctly, et cetera. So again, we need to figure that piece out as well, because I think although phone calls are easy, there's no visual aspect, right? So again, what are we missing? The teenage patient that's maybe lost 20 pounds and you didn't know because you haven't seen them for 6 months. At least with a visual, you might clue into some of that. So I think we need a better understanding of how we pair virtual care with in-person care. What are those high-risk scenarios where we stand to really make big errors? And how can we leverage technology to help us better understand, track that, and ensure quality? We need better patient education about how to engage in virtual visits and actual access to the technology that they need, and recognizing it can be actually increasing inequities for some groups. And then we need compensation models that work for physicians to motivate them to keep using this technology in a productive way and not just download the cost of it onto them. Because I think that's been honestly one of the reasons we have not seen the innovation in our healthcare space. Is any of these new things, the cost is actually borne by the physician, right? New EMR, you have to pay for it. Online scheduling, you have to pay for it. So we work in this strange environment where we don't have the ability necessarily to adjust our bottom line unless we see more patients. But then a lot of the costs of innovation in the system are being borne by physicians. So that just doesn't really work out. So I think that's another barrier. So I think we need to reinvent, again, just the way we are delivering care altogether. And I think that's what we're hearing from neuro doctors. People entering the system now are like, I don't want to work in the system the way it is now. So I think we have to park our fear and do a redesign. I worry that this tinkering around the edges, which is, I think, what we've been doing for a long time, isn't really going to get us where we need to be.
Thanks, Catherine. I think you hit on a lot of different points there, especially as it pertains to how do you develop the digital infrastructure that's going to be required for a 21st century delivery care model that people are going to perhaps demand in now a growing on-demand climate or culture in our society. And how do you square that with, who's going to actually be responsible for the development of that infrastructure? Who owns that infrastructure? And where does the funding for it come from? Zaina, you're a systems level thinker. You've worked around the world. So what do you think about that in terms of the digital infrastructure? How do you create it, and then how do you ultimately fund it in a way that that people can use, people can adopt, and then ultimately, hopefully, is sustainable?
Yeah, look, I hear the Canadian conversation about, and to me, virtual care is not technology; it's not innovation. It's just good business process optimization. Just like right now, we're doing this conference virtually. There was an alternative to do it in person. It just didn't make sense. So to me, that's actually not the value of digital. The value of digital is we're more intelligent. We are more responsive, and information flows and is communicated a lot more real time. Putting a doctor on Zoom, who cares? There's still a doctor. It's still time. It's still your fate. Like, that's not going to modernize healthcare. That's just what should have been happening a long time ago. So most places in the rest of the world, they elevate the conversation to not who's going to pay for whatever technology to allow you to do scheduling. It's just like you get efficiencies when you include technology that allows you to do more with the existing resources you have. So it's kind of self-funded. So most places you buy the outcome you want, and the people delivering that outcome figure out what combination of humans, capital, and tech they're going to combine to deliver that result. You don't pay for the pieces. You don't pay for the minutes of a person's time plus the software plus the hardware. That's just not how you get value out of, labor or capital or tech. So I wish we would elevate the conversation there. I think we're still treating virtual care as some binary in-person versus not in person. That's just not where the value is. And that's what most countries are doing. Look, I work for the biggest virtual care company in the world. We have 80,000 clinicians. We enable about 50 million people in a year to access care agnostic to place. It might be video, it might be a phone, it doesn't matter. And we manage 750,000 people who have complex chronic illness through a 100% digital model, right? They do not need an in-person exchange when they're managing chronic disease with amazing results. So that's kind of some of the spirit I'm trying to bring to the Canadian conversation is let's get out of these binary small conversations and say, what do we want for our people? And let the people who know how to do care figure out their combination of technology and humans to get that and pay them for the result.
And given your experience so far with this company or with your experience in this place, do you feel like when we talk about healthcare here in Canada, it's a very different way to conversate compared to other places? Why is that? And or do we have any hope here to be able to disconnect a conversation about cost, structure, payer, and an outcome in the quadruple aim that everyone talks about anyhow?
I honestly don't have a ton of hope. I think not everyone agrees with the one or two, ways we're going to finally modernize, but everyone would agree it'll be when patients and their families wake up and, Catherine, and you've mentioned, coming out of COVID, we realized a lot of things we didn't before. We were kind of in a benign naivety about where our healthcare system is at. I don't think Canadians are upset enough. I don't think access is so bad that they're kind of going to riot in the streets. We're maybe at a tipping point. However, I do think a new tipping point has come, which is what's going on with our workforce that really was not in the conversation before. And again, not supply, not shortages, just the lack of joy in work, all the burnout risk. I was talking to a couple ER docs last week and they're like, I'm scared to go to my ER shift tonight because I know half the nurses are not going to show up. They're just not showing up because they can't handle it. So I suspect that's going to open up a whole new conversation to finally try, like I said, to rebase things. Until then, I have no hope, I'll be honest, for Canadian healthcare to heal itself. What I think will happen is a bunch of new entrants are going to come into this space. They're going to provide an amazing experience, high clinical quality, very affordable, and Canadians will switch, and that's okay. We might have two systems going on, but that's what I think is going to happen. That's exactly what's happening in a lot of places around the world where the dominant central health system hasn't been able to change at the pace that the world is changing around them.
Catherine, how do you respond to perhaps a marketplace that is shifting in terms of its expectations? So whether you call it the Canadian consumer or the Canadian patient, how do you align sort of interests in a way that ultimately, and all of us on this, I think, call want to be able to provide excellent care, provide better outcomes for patients, get them the access that they deserve. So how do you manage that in a very, what I would say is a politically charged environment such as ours?
Yeah, I don't disagree. I think it's so challenging for so many reasons, as we've been hearing. But I also agree, disruptions happened in every industry. And I think it is coming in healthcare too. I mean, we already are seeing that in some levels. I think what's always challenging with disruption is, kind of who can access the disrupted technology and who can't. So that needs to be kind of considered. I think one of the things that's challenging in healthcare is we know everyone needs it at some point, and there's going to be people that can afford to probably jump out of our system and perhaps get into some of these new innovations, and there's going to be people who can't. I totally agree that there's no reason these things could not be happening within the system we have. It's so slow, right? Change is so slow, and there's I think so many challenges with the different levels of government that we have and who's responsible for what and making decisions that really also hampers any real innovation or change. Knowing that the federal government's one of the big funders, but then the provinces all want to do things the way they want to do things, and that tension often, I think, really blocks any innovation as well. Plus, it is sort of, that sacred cow in Canada, right? Like that no one wants to really talk about changing the system because it has sort of become part of our national identity. So even though it's not actually really working for anybody, any kind of talk about real substantive change to it, I think does evoke a lot of politics and sort of fear mongering in a way, because I think it's true. Like, is the system, what are we getting for what we're paying? I mean, it's a huge cost. It's one of the biggest expenditures in our country for sure, federally and provincially. Yet what are the outcomes we're getting for that? Not only in terms of patient outcomes, but as we're, just talking about outcomes for the people using the system on both sides, patient satisfaction, but also providers. And I think it is true. I think that the next crisis we're facing is that human health resource crisis, and people just sort of throwing up their hands and being like, I can't do this anymore. And I think we're just week to week, we're just hearing more and more of this. And at what point does the whole thing just break down as it is? I love hearing what our other speakers sort of saying about the type of innovation she's doing. And to be honest, like, I would love to know more about that. I certainly don't consider myself someone who has a full understanding of what all that could look like. But there's so many people that have this knowledge and these big brains. It would just be amazing to be able to actually tap into that more and start to be able to hold our governments accountable for where we're at. But what I see is just we have these never-ending sort of meetings, right, with bureaucrats and conversations, and nothing really ever happens. So it probably will be patients and people voting with their feet in terms of that innovation that needs to come, because eventually what we have now is just going to stop working. But I think it is true. It's kind of right now we're almost like at this tipping point where, it's true. People are kind of just getting barely enough to kind of tolerate it. But, how much longer is that really going to move forward? I worry I'm not sure it is going to be that much longer. So what do we do next? I think it's not an easy question, but I think perhaps the first thing is everyone sort of admitting that what we have doesn't work. I think I feel like we're sort of like holding on with our, claws to the remnants of this system that's not really working. And I think we really need our governments to admit that it's not working. And perhaps we just all need to keep getting louder about that and start insisting on something different. But how that happens and when that happens, I think it's really hard to know at this point.
Yeah, I think you're right. I think that's, being able to try and decouple the conversation emotionally, politically from really our ultimate goal, which is better patient care. I think that is, if we can find that recipe, that's the secret sauce in being able to let innovation come in, let this disruption happen in a meaningful way, preserve the sanctity of the Canadian healthcare system, but frankly, understand that we got a whole lot of work to still do. I want to shift gears a little bit. Zaina, we talk a lot about digital infrastructure, and you can't talk about infrastructure without data. And this concept of who owns data, who will own data. And then if you look at other places around the world, and even in our own country, Newfoundland, for example, who is now seized with this ransomware issue that's now frankly paralyzing its entire healthcare system practically overnight. Where do we go here from sort of our nascent understanding of data collection, data ownership, and then how does that overlay into these sort of new sort of nascent concerns about not only data privacy, but also data security?
I think they're two decoupled issues, right? So I'll just start with the latter. Getting hacked, whatever, place data is held, that's just a part of the 21st century, right? Healthcare is hacked all the time. We just don't see it in the headlines, including paying out the ransoms very heavily in Canada and around the world. So, a capability for cybersecurity talent, just is going to be a non-negotiable, just like you had to do that for privacy before. To me, that's separate from the emancipation of data and the value of all these secondary uses of data. And we've had very narrow uses for data in healthcare, and it's been locked in prisons, right? So the old model, which is still largely in play today, and this is to get to your first point, is that wherever the data is generated, that's the custodian, and it literally is locked in, and we only let certain people who are credentialed to interrogate that data, like academic scientists and that kind of thing. Well, wow, talk about not getting value out of your data. So where the world is going, and again, other jurisdictions are already there, so it's not like it's hard. We don't have to debate it. Mammals are the same, whether they're in Estonia or Canada, is that the data flows to and through the patient. It's their body. It's about their life. And if it got generated at a hospital or at a primary care or at a pharmacy, great. But it's about me. It goes to and through me. And there will be business models to enable that. And some are owned by patients, like co-ops, banks that kind of hold the data. And it could be other custodians. So I think that's clear. And that's when data flows, care is better. And especially when it flows to the patient, because an informed patient performs better. We know that. That's like evidence. So I think so then if you keep that in mind now, all these entities that held on to the data for whatever reason need to figure out a way to let it flow. And of course, there's technology to do that very easily. And last thing I'll say on this big privacy, I honestly think it's a myth. Like, we love to say it as if that's a reason not to modernize. It's like, no, just like, if you manufacture a new curling iron and you need to plug it in the wall, there's a standard to make sure it's safe. There's, privacy by design is a pretty well-known methodology. Like, it is not a reason not to do something. It's just, it has to be done. And I think our infrastructure is getting better and better on that. I'd say where we're behind is definitely cybersecurity.
Yeah. Yeah, thanks. And and we talk about privacy, and most people would say, I don't really care that my chest X-ray can be seen by someone else. But maybe someone's mental health issues, for example, would be a different scenario where that might pose a problem. But I do think that, as you're describing, there is also an evolution in the law about privacy and data security and data privacy, and that is happening in real time in this country and abroad. So I think that is, in my opinion, less of a concern compared to, as you're describing, whole systems are inaccessible now, or you can't even. So, for example, there are circumstances where you couldn't even administer a medication because the system was seized by nefarious actors in the space. And I also have concerns about how Canada specifically is going to continue to become targets as a proxy war between major countries around the world that we're seeing in real time. Catherine, maybe shifting gears, maybe one last time before we sort of wrap up here. We talk a little bit about advocacy. We talk about moving the needle. We influence policymakers, influence politicians, influence political parties. Has the role of the healthcare worker changed in the past 20 months? How is it going to continue to change? And how do we ensure that our work, whether it's advocacy related or other, is political in a nature that allows us to see change, but also remain nonpartisan, given the diversity of viewpoint within our own communities, but also more broadly held in society?
Yeah, I think that's a really interesting question. I think we have seen a huge change. I think with COVID and just how rapidly information's been generated and different opinions about what should and shouldn't be done, we've seen a lot of healthcare professionals and scientists really take to different platforms to try to share their thoughts and information and engage in debate and conversations about things. Twitter, social media. There's been all sorts of new levels, I think, of information sharing and engagement in those spaces that we haven't maybe seen as much before. And it has, I think, a real ability to impact the narrative and the direction. And I think that's another big difference, right? Historically, information was kind of largely controlled by people who wanted to hold it near to them. Now that's really changing, right? There's so much more information out there that people can access. People have much more ability to share their own opinions with people broadly. These platforms allow you, some people are reaching hundreds of thousands, millions of viewers. I think, unfortunately, in COVID, we've also seen how nefarious players, like people promoting misinformation, can leverage that to unfortunately, educate the public in a bad way. But I think, we actually kind of have no choice now as healthcare professionals and leaders to be on these platforms, to be sharing our thoughts and to be educating the public, and also engaging the public in these conversations, because that's where people are getting their information. And I totally agree that, people need to be educated, that, knowledge is power, and the more people know and the more people can engage, the more they can make those better choices. So I'm not really sure we can stay out of politics or stay out of these conversations as providers. I think, we've heard that people saying, oh, stay in your lane, this isn't your space. But I mean, health is political. There's no question. I mean, just the very fact that our politicians decide how our healthcare system runs, who gets paid what, how it works, whether or not we adapt these innovations, makes it political. So I think we sort of can't ignore that. I do think we have a role to play in that space. And I think the more that those of us who really are driven by that desire to serve our patients can be in those spaces, advocating, speaking up, calling out things, raising concerns, I think we can see change. And I think we've seen that throughout the pandemic. I think certain things happened because people were speaking out that may not have happened otherwise, that in the end were positive things for communities, people, patients. And I also think it's just we as healthcare professionals also get this opportunity to learn from others, right? Like just even this conversation today. I'm not an expert in technology. I've learned a ton hearing about what's going on in these other spaces. So I think it also creates that opportunity for us to broaden our minds out of what we've been trained to know, what our mentoring taught us, what we were sort of taught about the system and how it should work. And we can also break out of some of those silos and ways of thinking by engaging in these platforms with others who have this knowledge that will help us actually think differently and demand change for our patients. So I think, I think the kind of the genie's out of the bottle, like this is the space we need to be in. I think being a leader and an advocate and being out in public and engaging in these conversations is sort of the way forward. And I think it's also going to be critical in this health systems transformation that we're talking about, right? The more and more healthcare professionals are out there saying, you know what, actually, guys, the system is broken. No, actually, the system has collapsed. And speaking that way to the public, the more citizens are going to be like, hold on a minute, like maybe what the politicians are saying to me isn't actually true. The people inside the system are saying it's not working anymore. And maybe that's part of how we bring about the change.
Really well said, Catherine. Appreciate that viewpoint, actually. I know we have a few moments left, so perhaps we can maybe sort of focus in a little bit on some parting thoughts that you might have. If you're thinking or speaking to the next generation of leaders, what's sort of the one or two take-home points that you want them to be able to take away from this about healthcare, but also about technology, innovation, and maybe the future? Zaina? Oh, you're muted.
Sorry. Now, maybe I'll make two closing points. So we have a radically unsustainable system, which means that the system's ability to deliver care, it far, far is lower than the demand for services, and that's not going to get any better. When that means your business model is broken, right? When you can't do what you need to do at a cost that's acceptable to society, technology is the only way we're going to be able to make a dent in that. And technology replaces labor and capital. When I say replaces labor, it doesn't mean anybody ever loses their job. It's impossible to lose your job in healthcare. There's way too much to do, but it does change a lot of roles, care models, et cetera. That's one. The second is everything will move to the home. That's why I did 4 years as a futurist in home healthcare. Today, right now, most hospital care, inpatient care can be done at home, about 70%. Primary care, most at home. Outpatient care, your specialist visits, home. Surgeries will be done at home. There's already a lot happening. Imaging, most of it can be done at home. There's mobile imaging. Labs, your lab work, you don't need to go to collection center, home. It'll be replaced anyway, blood work with just digital versions of that. Pharmacy, home, you don't need pharmacies anymore. So if all things will go to basically care anywhere, then think about what that does to our extremely facility-based and visit-based paradigm of healthcare. That's the opportunity, and that's not just tech. Tech has a huge role, but new role changes for people, business model changes, and absolutely you can't do any of this if policy doesn't stay ahead of things. instead of what our policies mostly do today, which is protect the past.
Thanks, Zaina. Catherine?
Yeah, I agree. I think we have to just say out loud, the status quo is not working. And we have to step, I think, outside of our own industry and the way we educate ourselves to learn from people that are innovators, people that are in these spaces, to actually bring them into what we do to change our ability to think about these things on a different level. You know, we basically in medicine learn through a mentorship model, but we're being mentored by people who think in a certain way because it's a system that's putting out a certain type of product. And I think we need to bring new people into those systems to really challenge our thinking. You know, we absolutely have the expertise around the medicine, but we don't have the expertise around these other issues, and really, nor do we have the expertise in innovation. So we have to build these different partnerships. And I think if we have to build them early, we have to shift, you know, who we're training, how we're training them, and we have to bring this thinking around innovation right into the beginning of what we're doing so that we actually are outputting physicians who are ready to be in these new spaces and not, you know, wanting to persist with the status quo. So I think my take home would be the status quo is broken. Let's stop with policies or decision making that actually invest in maintaining it. Let's instead embrace innovation. Let's get creative about who we're learning from and how we're thinking, and let's get on with the business of change.
That's very well said, both of you. Provocative, inspiring, futuristic, but really, you know, kind of in the palm of our hands in terms of the ability to get there and the decisions that we make now to be able to affect change. So I wanted to thank you both for a really engaging discussion. In fact, I learned so much. I'm excited just sitting here thinking about the future. And so hopefully we can continue this conversation in many more broader ways that affect all of our not only our patients, but our communities, our neighborhoods, and ultimately the society that we're building for the future. So with that, I wanted to thank you once again, and thank you everyone for attending. This, I think, hopefully was a very stimulating conversation that leaves a lot of new ideas in our minds for the future. So thank you so much.
Thanks, Adam.